Hello, my dear candidates. Good evening to all. How are you all? Is that my voice is clear, doctors?
Yes, ma'am.
Yeah.
Yes, ma'am.
Yeah. So today, few candidates exam very soon. So I just reschedule it tomorrow, inshallah. Regarding hematology medicine session will be taken at the noon time. So today, hepatobiliary system will be discussed. Actually, in surgery, few topics I always emphasize those topics that you will face exam like liver abscess, pyogenic abscess, inflammatory bowel disease, colon cancer. So these are the common topics they commonly asking abdominal obstruction, obstructive picture. Okay, so pancreatic cirrhosis, pancreatitis, cholecystitis, MRCP, ERCP. These are the common topics. So we have to keep clear on those basic cause this question, and I will discuss few question today with my candidates, and it will be more specify those point where we face confused. Today, few candidates was asking me personally regarding the antibiotic use and open own exploration. Actually, doctors, this is also basic. And few candidates also asked me, ma'am, how I understand it's the best definitive. Just a few points. Initially mean what you will do right now. After operative system, it could be the appendectomy exploration or whatever the surgery. Initially, if fever, temperature high, leukocytosis, these are the clue there, and they ask initially. So leukocytosis, temperature, and there's a tenderness still not oozing or there are no pus discharging. Hmm? There's no clue like that. So only temperature, tenderness, leukocytosis, WBC count high. So we can start antibody, though we need exploration. It's a definitive. We have to understand question first. For passing exam, the clue is that we have to understand question first. Then if they ask directly what is the definitive step you will do, so it's exploration. You have to do exploration. Rather than sometimes we have to imagine CT abdomen before exploration to see whether is there any abscess present or no, whether we have to do incision and drainage or not. Because how we have to understand if there is no clue of any discharge, if there is no clue of any discharge, we can do an imaging test like CT or ultrasound to see is there any abscess present or not, and we can do incision and drainage. But if there is a clue, there is a discharge, oozing, pus, so we have to do exploration. Somewhere they ask initially. So initially actually antibiotic coverage. This way they do the exam question, but I have to specify those question answer more that what I have to do. So the question was discussion is that if patient without discharge only tenderness, we can start antibiotic. If need exploration, we can do exploration later. So this way we have to remark those questions. Okay. So severe sepsis is procalcitonin. Whether many candidates are working in the ICU, CCU, they know. Septicemia, we have to do first. Septicemia marker is procalcitonin. Suspected infected necrotizing pancreatitis. Suspected, so the necrotizing pancreatitis means what? Pancreatitis done, acute setting done, and it necrotized and infected. Two state, necrotized and infected. So if it is below 3 weeks from the disease onset, so acute pancreatitis will be below 3 weeks. Chronic mean more than 3 weeks. So temporary, I said as infected as they said, we have to start antibiotic. If it is resolved, it's okay, excellent. But if there is any abdominal syndrome, like any perforation, any bleeding, we have to do laparotomy. Neither we are giving antibiotic, but presentation ongoing, no improvement. Okay. Ongoing presentation, we have to do percutaneous drainage versus endoscopic drainage. First, question you will face in the exam. We are giving antibiotic but not improving. Okay. We have to do percutaneous drainage first, then endoscopic drainage. If it is resolved, it's excellent result. But we already given antibiotic, we already done the drainage, but still sepsis ongoing. After drainage the pus, percutaneous or endoscopy, but there's no resolve. So reintervention form like percutaneous drainage and endoscopic drainage we can do to resolve those infected sites. So my dear candidates, we can do re-intervention, percutaneous drainage and endoscopic drainage. Okay. So already it is ongoing sepsis more than 3 weeks from disease onset. So already 3 weeks done, endoscopic debridement done, and we already done microscopic intercellular debridement, all done. But if resolved, it's okay. But if still ongoing, we have to do laparotomy. So see, till laparotomy step, to reach laparotomy state, what are the stage? First, we started antibiotic. Septicemia ongoing, we started the drainage. Septicemia ongoing, 3 weeks, more than 3 weeks, we started the debridement, re-intervention done. Then ongoing infection, we started laparotomy to see the site of infection. So this way, steps we have to remember. Question practice always I emphasize that we have to do more question practice. So question 1, though question discussion very important part of our course. So whether if we do wrong, it's not problem. Okay. The same question you'll face in the exam. So that is the point. Question 1 will be discussed with me, Kutsia. Dr. Kutsia is here.
Yes, ma'am. A 60-year-old male patient complaining of right upper quadrant pain, yellowish sclera, history of chills and rigors, no vitals are provided. His labs shows high LP, high direct bilirubin. What's the most important initial step of management? Right upper quadrant pain, yellowish sclera, history of chills and rigors, no vitals are provided. Ma'am, first of all, initial step is we should start from antibiotics or ERCP. I'm confused in these two.
You can't be confused. You have to be determined. First of all, patient chills and rigors. Okay. This patient come to your hospital and you are seeing this is the obstructive picture. High alkaline phosphatase here, high direct bilirubin, all are the obstructive picture. ERCP is the definite. ERCP is a definitive. So they ask initially.
Initially, ma'am, antibiotics because patient have chills and rigors.
Actually, that is the same question when they ask, if they ask definitive or
ma'am, IV fluid, I think. IV fluids.
No. Don't be confused. Why and where the IV fluid indication? Is there any clue that you have to start IV fluid? Why?
No, ma'am, there's no clue.
No clue. First of all, they ask there is a chills and rigors, the obstructive picture. So abdominal ultrasound, no value. Antibiotic I have to start first because there's a chills and rigors. IV fluid, no, there is no blood pressure low. There's nothing that I have to start IV fluid. No, we can't do. We have to do actually ERCP, but if they ask what is the best step, so if they ask best step of management, same exam question, we have to do ERCP.
Mm.
Clear? So
Yes,
don't be
ma'am.
confused. The clue is that abdominal pain, high chills and history of the chills and rigors. Even if they didn't give this chills and rigors picture, they ask best step. Best step always ERCP.
Mm.
Okay?
Okay, ma'am.
Clear?
Yes, ma'am.
Okay, I'll discuss this question later again. Question 2 will be discussed with me, Dr. Saba. If Dr. Saba is not here,
Yes, ma'am. Assalamualaikum, ma'am. A 58 years old woman comes to the emergency department because of 2-day history of worsening upper abdominal pain. She reports nausea and vomiting and is unable to tolerate oral intake. She appears uncomfortable. Her temperature is 31.1 degrees C, 106 Fahrenheit. Pulse is 19 per minute. Respirations are 18 per minute, and blood pressure is 132 by 85 mmHg. Examination shows yellowish discoloration of her sclera. Her abdomen is tender in the right upper quadrant. There is no abdominal distension or organomegaly. Laboratory studies shows hemoglobin is 13, leukocyte count is uh, uh, 16,000, urine nitrogen 25, creatinine 2, alkaline phosphate 432, alkaline aminotransferase 196, aspartate transaminase 207, bilirubin total 3.8 and direct 2.7, lipase is 82. Ultrasounds of the right upper quadrant shows dilated intrahepatic and extrahepatic bile ducts and multiple hyperechoic spheres within the gallbladder. The pancreas is not well visualized. Intravenous fluids, resuscitation, and antibiotic therapy with ceftriaxone and metronidazole is begun. 12 hours later, the patient appears actually ill and is not oriented to time. Her temperature is 39.1 degrees C, pulse is 105, respirations are 22 per minute, and blood pressure is 112 by 82 mmHg. Which is the following most appropriate next step in the management? A. Abdominal CT scan. B. Laparoscopic cholecystectomy. C. Uh, MRC cholangiography. Percutaneous cholecystectomy. And E. Extracorporeal shock wave lithotripsy. And F. Endoscopic retrograde cholangiopancreatography. So according to scenario, patient have 2 days history,
okay.
and
And
his presentation is abdominal pain and also having nausea and vomiting and
mhm.
unable to tolerate anything oral intake. So he is on and uncomfortable. But pressure vitals are, ma'am, in normal in range initially. Blood pressure is
Okay.
132 by 85, and leukocyte count is, ma'am, leukocyte count is 16,000.
Mhm,
So it's mild high,
mhm.
And on his labs on ultrasonography, right upper quadrant showed dilated intrahepatic and extrahepatic ducts and multiple hepatoechoic sphere within the gallbladder. So the point to be noted is its ultrasonic uh, presentation, where there is a dilated extra and intrahepatic ducts with multiple hepatoechoic spheric shadows within the gallbladder. The pancreas is not well visualized. Pancreas are not visualized. IV fluids resuscitation and antibiotic therapy will be started, and antibiotic ceftriaxone and metronidazole are given. After 12 hours, the patient appears ill and is not oriented with time. Temperature is 98. Ma'am,
What is
the
the
most
diagnosis?
yes, ma'am. What is the diagnosis, ma'am? There is obstruction in the gallbladder duct, so maybe there is a gallbladder stones.
With
Uh,
infective, say acute cholangitis. Cause
yes,
glucose
ma'am.
is high,
Ma'am,
ERCP high, and the ALT, AST high, but not ALK high. Alkaline phosphate is not high. So alkaline phosphate is high. Alkaline
yes,
phosphate
ma'am.
is high means it's obstructive. ALT, AST
Yes, ma'am.
high also is a cholangitis.
Obstructive
Obstructive
hepato. Yes, ma'am. There is obstruction in the um,
gall, bile duct, bile duct.
gallbladder, bile ducts. Oh, yes, ma'am. Bile duct.
So what you
Extra
will do?
intrahepatic.
And already you given an antibiotic and fluid. So what you will do? Is there any role abdominal CT? Any role? Excluding method. Do excluding method. Is there any role CT?
No, ma'am. There is no. We exclude option A. There is no need of CT scan, and there is no need of
Post
percutaneous.
patient. Post patient on infective state we can't do. Okay.
Yes,
Laparoscopic post-hysterectomy we can't do.
yes, ma'am.
MRCP, magnetic resonance cholangiopancreatography. So MRCP, no or yes.
No, ma'am. I'm add MRCP in my option.
Mhm,
Then percutaneous option D is also excluded.
mhm,
Option E is also excluded, and option F and option C. These are on my list.
mhm.
So,
So when ERCP, when MRCP? They say,
I
Dr. Saba, they say what is the next step? So next step means we have to do visualization and we have to see the obstruction. So
yes,
visualization and dilatation, both I have to do.
yes, ma'am.
We have to
Ma'am,
do by. Mhm,
I select option 7. FF, endoscopic retrograde cholangiopancreatography.
this the answer is the question F. Excellent.
Yes, ma'am.
Thank you. So why this is the question collection from the image question, though this is the large question, but the thing is that from one question we can get more information, more knowledge. So the thing, thank you, Dr. Saba, you done very good. So see,
Thank you, ma'am.
ERCP, endoscopic retrograde cholangiography, few countries very newly joined. For them, I always highly recommend to do excluding method. Even we don't have knowledge, but we have basic. If we do so, we can reach our correct answer. But whatever the exam you do in your life, do excluding method. Okay, I am a doctor. I understand ALP high, so it's obstructive, but initially they ask next step. So I can't do post-hysterectomy, I can't do pericardial gel. We have to do visualization and we have to see the obstruction. So see what they explain. Explanation is a biliary drainage via endoscopic retrograde cholangiopancreatography is the treatment of choice acute cholangitis. In mild case that respond well antibiotic therapy, but here ALP high, WBC count high, ERCP is an elective procedure, elective to take place 24 to 40 hours after clinical involvement. We already started IV fluid, we already started antibiotic. So if patients who do not respond well to antibiotic or who have severe cholangitis, sign of sepsis, ERCP should be performed emergently. Here we started antibiotic, still presentation what? Presentation Dr. Saba tried, she tried her best to understand. Antibiotic we are giving still, you say, because they are the option we have to understand very well. Why ERCP? We started IV fluid antibiotic, but still temperature high, 102 degree Fahrenheit and pulse higher due to temperature. So it is not responding to our treatment. So emergently we have to do ERCP. This is the option. Mental status already changed. Encephalopathy like presentation, Dr. Sabar's case. Tachypnea, tachycardia, high fever, low blood pressure on admission despite treating ceftriaxone, metronidazole and antibiotic and IV fluid. So immediate to ERCP. Clear, doctors all? This step we have to maintain. Dr. Kusia's case regarding the management, septicemia, and Dr. Kusia say IV fluid and antibiotic was confused. So see, initial treatment of the septicemia, identify the cause and treatment the septicemia. So hemodynamically patient stable. Dr. Kusia was confused either fluid or antibiotic or ERCP was confused. So Dr. Kusia's case, only pain and high chill rigor with yellowish discoloration and high LP bilirubin obstructed picture. So see what they said. We have to identify the cause. We have to see the hemodynamical stability or not. Is the patient on shock or not? We can start empirical antibiotic first. Okay. So administer empirical antibiotic to see empirical antibiotic therapy. So biliary infection. So grade 3 acute cholangitis. Acute cholangitis within 1 hour of presentation, Dr. Kusa's case. So you have to start empirical antibiotic and we can keep NP. It's a second step. So see, it's a second step. Then IV fluid, then electrolyte depletion, then according to the pain, fever, NSAIDs, you can give later. ERCP is the option to see the biliary atresia and cholangitis. Clear, Dr. Kusia, the steps and all. Okay. So this way we have to select our option: patient stability, viability, infectious cause, empirical therapy. Okay. So natural history of gallstone. See, patient may be asymptomatic. Patient may be asymptomatic. It could be the biliary colic, biliary duct colic, or acute cholecystitis. So asymptomatic case 2 to 3% per year or acute cholecystitis 0.2% per year. We have to remember that biliary colic recurrence rate 20 to 50%, but symptomatic presentation more than asymptomatic. Symptomatic presentation for the chronic cholecystitis or biliary stone cause, pancreatitis, cholangitis, jaundice. Okay. So we have to remember that gallstone, the clue for having bile duct stone, acute cholecystitis, it can cause chronic cholecystitis. Even if it is age more than 50 years, we have to think regarding the gallbladder carcinoma. This is the high yield picture for the exam. Everyone after my session must to remember, must to remember, must to know. Because these are the basic we have to know very strongly. After session, it will be uploaded and strongly remember those points. Just for review, I am telling those points. Cholelithiasis presentation is due to the gallbladder stone, and cholelithiasis is due to bile cholesterol in which bile status impaired by. So when bile cholesterol there, bile can't circulate, which cause gallstone. So clinical picture will be that it could be asymptomatic but biliary colic picture, right upper quadrant pain. Laboratory finding due to the bile duct can't flow, it could be normal, but in ultrasonography we can see gallstone or posterior acoustic shadow. We have to remember the management, supportive management analgesic or cholecystectomy elective support for the symptomatic patient. Okay. Acute management always we have to supportive management. So cholelithiasis patient, gallstone presentation, bile acid can't circulate through the biliary tree, and presentation of gallstone due to the gallbladder and patient biliary colic presentation, we have to do supportive management. Laboratory finding and blood test will be the normal, and but by ultrasonography it can find out in the gallstone with posterior acoustic shadow. Next is choledocololithiasis. Choledocololithiasis means same as gallstone in the common bile duct. So common bile duct, cholelithiasis means gallstone in the gallbladder, but choledocololithiasis means common bile duct, stone in the common bile duct. So cholelithiasis means gallbladder stone, but the thing is that bile cholesterol oversaturation, bile status, impaired bile circulation, and where gallstone formation. But in choledolithiasis, bile duct stone. So choledocolithiasis, we have to remember that gallstone migrating. So right upper quadrant pain, jaundice, and total bilirubin will be high, gamma GT will be high, alkaline phosphatase, all are the obstructive picture. They are same way and they ask diagnosis. They are DHA, heart, MO, every candidate. Same, this is the typical scenario. This is the 4-star. Choledocolithiasis presentation, laboratory finding, ultrasound finding, common bile duct will be the dilated, and management. Analgesic and specific is elective cholecystectomy. Acute cholecystitis, they ask commonly management. Acute cholecystitis is the acute inflammation of the gallbladder. Biliary slash there, inflammation of the gallbladder. So presentation will be same as Murphy's sign, will be positive fever and right upper quadrant pain. And there will be the WBC high, CRP will be the high. This is the laboratory finding. But acute cholecystitis means what? Gallbladder inflammation. So ultrasound finding is a very important to determine. Even we are the physician, we have to know there will be the thickening of the gallbladder and edema, hidden skin, non-visualization, and there will be the gallbladder more than 4 hours after radioactive test administration. How they ask in the exam? We have to do cholecystectomy. Initially, we can start IV antibiotic according to the presentation. Though here WBC will be the high. So, my dear candidates, choledocolithiasis, acute cholecystitis, common scenario in the exam. Okay. Now, cholangitis, severely important. I said severely means highly important. Okay. So, mild, moderate, severe, according to the our grade. Both three pictures are the very important. So, cholangitis, just I discussed with Dr. Saba's case. Already I discussed everything. Same as well. Because Saba was confused what I will do. So see, just I'll discuss one point, Dr. Saba's case. We do ultrasound initially to see the biliary dilatation, but the Dr. Saba's is already obstetric picture, fever. We already started the antibiotic fluid, but still not responsive. So MRCP, when we do Dr. Saba's case, MRCP we do if diagnosis is uncertain, but Dr. Sabas, every lab value, every symptoms diagnosis confirm it is cholangitis. So when started antibiotic fluid and patient is not responding and patient temperature high, we have to do ERCP. Explanation I discussed with Dr. Sabaskis must remember that why ERCP. MRCP we do only if we don't know what is the diagnosis and uncertain diagnosis. Mostly, I always emphasize one point, my dear candidates. Remember, we always do ERCP. Okay. Now, management. As is opposed to me, but initially IV antibiotic. This picture very important for the exam. But Sasma is here.
Yes, ma'am.
Is there my voice is clear? Dr. Sabah saying my voice is not clear. Is that so?
Yes,
No,
ma'am,
ma'am.
it's clear.
Your
Now
voice is
clear.
clear.
Okay.
It's clear, ma'am.
Yeah. Okay. Now, Dr. Sajma.
Yes, ma'am. A 50-year-old male patient had a pancreatitis episode months ago, developed upper GI bleeding, scope was done, gastric fundal bleeding was found, sclerotherapy done, duplex ultrasound showed splenic vein thrombosis with patent portal vein. What is your management? Uh, Here is the splenic vein thrombosis with patent portal vein and okay, and the bleeding was found. Portal systemic shunt. Option A is splenectomy. Option B is portal systemic shunt. C is beta blockers, and D is somatostatin.
Mhm.
Um, my option will be option B, portal systemic shunt.
Okay. First of all, Dr. Sajma, you read your case again.
Okay. A 50-year-old
Patient
male.
presented with upper GI bleeding. 86
Yes.
months ago, and scope was done. So endoscopy done and gastric funnel bleeding was found. So we already done endoscopy and we already found bleeding there. And sclerotherapy already done, Dr. Sajma. So see, your case, you done sclerotherapy. Okay, and you
Okay.
seeing duplex venous ultrasound thrombosis. Dr. Sashma, listen carefully. Try to understand. You done sclerotherapy. You are seeing there is a thrombosis. So what is your management? Thrombosis there.
Um, Thrombolysis.
Thrombolysis. Is there any option here?
No, there is not an option. Option A, splenectomy.
Splenectomy. Yes. The answer is splenectomy. Okay, I'm discussing everything now. Thank you, Dr. Sashma.
Thank you.
I'm discussing. First of all, splenectomy is the answer. We have to understand splenic vein thrombosis. Clinical picture will be the upper GI bleeding, ascites, splenomegaly. We done ultrasonography, duplex ultrasound, CT, MRI, whatever the thing. So, see, thrombolectomy. We have to do thrombolectomy, but there's no option or anticoagulation, acute setting. But Dr. Saspa's case, already patient suffering months ago. Several months we done sclerotherapy, bleeding there, scopy done. Done, we start doing ultrasonography, duplex ultrasonography. And we already found there is a thrombosis, but it is not accurate in that it's a thrombosis now. No, patient is suffering long time. So in this case, chronic case, we have to do patient symptomatic, we have to do splenectomy. Dr. Sashma, clear or all? Okay.
Yes, ma'am.
Okay, so this indication of Dr. Salzman's case, if this clue, what are the clues? Sclerotherapy, bleeding, if there's no clue, patient suffering from several months, if there's not sudden onset, patient bleeding, and you done duplex ultrasound, you are seeing there's splenic thrombosis. We can do thrombolectomy, we can do anticoagulation starting, but no, patient suffering long time. We done everything step by step. We done scopy, we are seeing bleeding, we done sclerotherapy, there's also bleeding, and we done duplex, there is thrombosis. So now sclerotomy. So treatment of the sclerotomy, good prognosis. Always sinoatrial or left-sided portal hypertension. Complication is chronic pancreatitis. Okay. So Dr. C, this thrombotic picture, prehepatic, intrahepatic, posthepatic. It can be obstruction in the portal venous system, portal vein thrombosis, splenic vein thrombosis, Dr. Sussman's case. So it's the prehepatic. It can be intrahepatic, cirrhosis, cystosomasis. It can be sinusoidal obstruction syndrome. It's a portal hypertension. It could be. It could be the Barth-Cherry syndrome. Exam question, MH exam question, Barth-Cherry syndrome, very important. And acid exam question, Barth-Cherry syndrome. It's a post-hepatic. So, whether I will do anticoagulation, whether I will do stanting or dilatation, where I will do the splenectomy according to the presentation. Our patient, portal hypertension patient develop right heart failure or constitutive pericarditis. So, according to the patient presentation, I have to take steps. Question 3, one time they asked, but I feel many candidates may not be know the cause. Just for discussion, I want to discuss this question. If we do wrong, no issue. This question we discuss with Dr. Ikra.
Assalamu alaikum, ma'am.
Alaikum salam.
A 24 years old with history of appendectomy 5 years ago present with abdominal pain, distension, vomiting for 3 days. CT scan showed signs of intestinal obstruction and peritonitis. What agent is contraindicated in this patient? Propofol, ketamine, sevoflurane, and nitrous oxide. Ma'am, I think it's option D, nitrous oxide.
Why? Answer
Ma'am,
correct. I'm assuring you answer correct, but do you know why? First of all, you can say, ma'am, this may be the option. Abdominal pain. Patient come to 5 years back, there's an appendectomy done, and now it's distension and vomit in 3 days. Now CT showed there is an intestinal obstruction. So I can't do or I can't give nitrous oxide. Okay?
Yes, ma'am.
Thank you. Thank you, doctor.
Thank you,
So
ma'am.
thank you. So we have to understand few topics, few points. Nitrous oxide we have to remember nitrous oxide is a contraindicated if there is a bowel obstruction, presence of alveolar or any kind of pneumothorax. So these are the clue. We can't use nitrous oxide. So Dr. Ikra's case, patient develop vomiting, obstruction, peritonitis. We can't use nitrous. This is the pharmacological question. I have candidates there. So patient with potential ear space. Potential ear space means what? It could be the any emphysema presentation or vitreoretinal surgery with the first treatment, any history. So any vitreoretinal surgery, previous history of middle ear surgery or current block, so we can't use nitrous oxide. Pulmonary hypertension case, any metabolism, any storage disease, we can't use. So reasoning or explanation, I can't explain. I don't want to explain because just we have to remember the condition where we can't use nitrous oxide causology. before that, propofol indication, etoposide indication, ketamine indication, just I will discuss shortly cause somehow or somewhere they ask. Ketamine is a question mainly in the DHR hat, I forget where they ask. They just ask indication. So ketamine is important. Ketamine is the drug where we use in treatment resistant depression, treatment resistant asthma. Many clue there that we use chemotherapy, antidepressant drug, but patient is not responsive. So we have to start ketamine. Ideal emergency anesthetic for polytrauma. So polytrauma case, ICU sedation, we have to start ketamine. So mainly remember resistant of the asthma treatment, resistant of the depression treatment, we have to start ketamine. What are the characteristics? Characteristic will be intracranial pressure will be the high, dissociative aesthetics, psychomotor effect of the vivid dreams, hallucination, asthmatic, psychiatric patient. So you have to start ketamine. Another important shortly I'll discuss, not so all that's I'll discuss. Common recent exam question, opioids antidote, naloxone. This was recent, just a few days back, recent exam question. Opioids antidote naloxone, but we have to remember that naloxone indication allows also that if there in analgesia during induction or maintenance of anesthesia during anesthesiology or any major operation, if there are any muscle rigidity, cardiopulmonary resuscitation needed or depression needed, we can start morphine. Okay. Etomidate is not so important, but propofol, and beta blocker we can use in the sedation of the ICU. Propofol, it's a, actually it's a not bislol or bisochor. Just remember, propofol is a sedative. It's the intravenous aesthetics. So propofol we use sedation in ICU. So rapid sequence of induction we have to start propofol. It can cause hypoperfusion or possible respiratory depression. So we have to use this propofol very sincerely. Acute course study, just shortly I will brief. Patient presentation in hospital admission, supportive care. So determine the surgical risk, low risk, high risk. So high risk patient clinical improvement. Okay. So when I will declare patient has surgical risk. So clinical improvement we can do discharge. But clinical deterioration we have to do percutaneous cholecystostomy. Surgical risk evaluation. So percutaneous cholecystostomy we have to referral for evaluation of non-surgical gallstone therapy. Lower risk case clinical improvement, elective cholecystectomy during same hospitalization. Clinical deterioration, emergency cholecystectomy. So just for exam, I have to understand whether patient clinically deteriorated or not. If clinically deteriorate, emergency. If not, we can do supportive or elective cholecystectomy. Symptoms of cholelithiasis, my dear candidates, very highly important, my DHA hard candidates. Cholelithiasis, right upper quadrant pain, cholelithiasis, presence of acid, prediction of the concurrent choledolithiasis strongly. Common bile duct will be the more than 6 centimeter, 6 millimeters, so 0.6 centimeter. Bilirubin will be the high. So strongly indicate determine of this choledolithiasis. So we have to understand is the intermediate risk or high risk. So choledolithiasis, first of all, moderate age value, presentation, gallstone pancreatitis very strong value, common bile duct is strong, bilirubin more than 4. So these are the very strong value for the choledolithiasis. But high risk case, pre-operative ERCP, high risk case, then interval elective cholecystectomy. But intermediate risk case, pre-operative we can do endoscopic ultrasonography or MRCP. But the thing is that according to the presentation, we can do laparoscopy, ultrasonography or cholangiography. If stone present, we can do cholecystectomy or a postoperative ERCP, or we can do common bile duct exploration. Low risk case, we can do commonly cholecystectomy. Very important, my dear candidates, strongly remember these steps. Acalculous cholecystitis, just remember, acalculous cholecystitis caused by dysfunction of gallbladder, dysfunction or hypokinesis. Gallbladder, what is the risk factor for having cholecystitis acalculous? If we give parental nutrition, trauma, prolonged fasting, okay, dehydration, multiple transfusion, these are the risk factor for acalculous cholecystitis. Biliary cause of acute abdomen, you see here, MRI of the abdomen showing severe cholecystitis, thick wall. These are the thick wall. So biliary cause of acute abdomen patient present to your hospital with liver function impairment, jaundice. It could be the gallbladder stone, so upper quadrant pain. So first of all, we can keep in acute setting NPO than antibiotic IV. We can according to the presentation emergency basis cholecystectomy or cholecystostomy. So ERCP pancreatitis, cholangitis, pancreatitis, obstructive picture, suspicion of tumor, liver abscess, all are the urgency for having biliary cause of acute abdomen. So according to the presentation, we have to take management steps. Liver abscess scenario, pyogenic or hepatic. This is the pyogenic liver abscess. Just remember regarding this liver abscess scenario, secondary cause we have to understand. It could be the operative situation, it could be any other, like any traveling history, okay, pyogenic, or is that liver abscess due to any organism. So radiological percutaneous aspiration, we can do first line therapy. If initially can give antibiotic therapy 2 to 4 weeks, but percutaneous drainage initially and first line management. 80-year-old female, what they said, real scenario, just it was a recall that patient bedridden, hypertensive, diabetic, cerebrovascular accident, dementia, 1 week story. So you see all are the ischemic picture. So ischemic picture means it could be the an septicemia or it could be the an ischemic hepatitis. So patient bedridden, hypertensive, diabetic. Okay. So 1 week of antibiotic you can start if any infective source there. If no improvement, we have to decide ultrasound the following findings. So what they said, actually the real scenario this discussion was hepatic. You are seeing hepatic abscess, septation indicating perforation. Okay, pleural effusion reaction. So my case, just real scenario I was discussing. Patient diabetic hypertension bedridden, level of consciousness decreased, so encephalopathy developing, and patient urosepsis was pneumonia treating, so no improvement even given antibiotics. So we have to decide for the abdominal ultrasound, and abdominal ultrasound find that there is the effusion present and there is septation present or perforation of the gallbladder perforation. So this may cause, or this just may presentation. So see, another way, this is the abscess and this is the hemangioma. So abscess picture always there will be the leukocyte count high. Hemangioma picture also like that way, but the leukocyte count will not be high. There will be the bleeding picture. Septation will be there. They will give you in half candidates the picture of hemangioma or abscess, or they'll ask the management or investigation what you will do. First question will be discussed with me, Dr. It's Hira Abrar.
Yes, ma'am. Assalamualaikum.
Walaikum
A,
salam.
fif- a 50 years old male, known case of ischemic heart disease and diabetes, was admitted to the ICU with severe pneumonia and was treated with antibiotics. After 3 days of admission, he developed hypotension and treated with hydration and anatropes. On admission, labs were normal. After 3 days, LFT is abnormal. Total bilirubin 20 increased, very high AST and ALT 1000, mild increase in LDH. Ultrasound is unremarkable. What is the diagnosis? Ischemic hepatitis, intravascular hemolysis, ICU related jaundice, calculus, cholecystitis. Ischemic heart disease, diabetes, ICU, antibiotics, hyper, hypertension, hydration, and pneumonia. Diabetic. Ma'am, my diagnosis is acalculus, cholecystitis.
Yeah, it is a diagnosis, but what is the gynecologist cause? It's A one, two, three, four. What is the cause? Your answer
Ma'am, first,
acalculus. Your answer
yes, ma'am.
acalculus causatis.
Yes, ma'am. It because here is also already age is 50 years, already suffering from ischemic heart disease and diabetes. He had attack of pneumonia. He was treated with antibiotic in the ICU. After 3 days of admission, he developed hypertension, and then he was hydrated and treated with inotropes. And after 3 days of admission, his LFTs got deranged, in which total bilirubin was AST and ALT was raised, and LDH was also raised.
So see, Dr. Hira, basic. It's a basic. Patient ICU admitted. I just discussed
Yes,
this case recent. Just
yes,
now I
ma'am.
just discussed this question.
Yes, ma'am.
Patient admitted on ICU, but patient on what?
On
Patient on antibiotic due to
antibiotics.
pneumonia, septicemia, severe
Yes,
septicemia
ma'am.
due to pneumonia.
Yes, ma'am.
But the thing is that it's a acalculous causative, but it is not diagnosis. Diagnosis is what? For acalculous cholestatis, there will be one clue. What is that? Alkaline phosphatase clue. But there is no
Look,
alkaline phosphatase clue. There
ALP.
is only
Look, yeah.
they said only STLT high means hepatic
Hi,
picture.
hi. Yes, ma'am.
STLT high means hepatic picture high, cell damage. Cell damage. So patient
Ma'am,
ICU
then ischemic hepatitis.
is ischemic hepatitis.
Yes, ma'am.
So answer ischemic hepatitis. But here my always aim is try to understand that here if you tell me ma'am alkalosis causatis, where is alkaline phosphatase? There's no clue.
Yes, ma'am. There is no alkaline phosphatase.
There
Yes,
is
ma'am.
only STLT severely high 1000, severely damaged cellular picture. So it's a
Ischemic
ischemic hepatitis.
hepatitis.
Okay? Don't do wrong. Same question in the exam. Okay, clear?
Yes, ma'am. Clear. Thank you.
Second question will be discussed with me. Dr. Sneha Raj is here. Sneha Raj or Dr. Shruti.
Yes, ma'am.
Yeah, discuss this question.
A patient presents with a major burn, referred to surgery for 24 hours, symptoms of cholecystitis. What is the management? So, ma'am, the patient already had a major burn, so he's already in a septic picture and he's referred to surgery for 24 hours. Ma'am, to do ERCP?
Dr. Sneha,
Yes, ma'am.
say I am your patient and major burn. Okay, so see, and already major burn done. So you see, a major burn patient, what we do? We do ABC approach, airway, blood
Yes, ma'am.
pressure, circulation maintenance, and major burn done, and there is surgery 24-hour syndrome of cholecystitis. Yeah, after burning, it could be the what? the referred to surgery for 24 hours symptoms of cholecystitis. So it's a presentation after burn. I am presented to hospital with cholecystitis. It's not a major issue. Major issue is I already burned out. So cholecystomy tube, open cholecystomy, laparoscopic cholecystomy, ERCP. This case, how you will deal? Just think. ERCP to visualize the biliary tree. Is there any importance now? Patient already burned out. Now cholecystitis present. Why you will do ERCP? So it's excluded. I always practice excluding method.
Yes, ma'am.
Laparoscopic cholecystectomy, major burn patient, we need to take time for doing any procedure. So open and laparoscopy both excluded. If we give a tube to drainage those infective cholecystitis, if there's any edema, cholecystitis means inflammation of the gallbladder. There will be the slush, there will be the edema, there will be the whatever any the gallbladder will be the highly bulge out. So if we do a tube and it drains out, so it will be helpful for my patient, Dr.
Yes,
Sneha.
ma'am.
Clear? In
Yes,
this
ma'am.
burnout patient where they say major burn, we can't do any procedure. We can't. We have to do wait till stabilize the patient. Clear?
Okay, ma'am.
Yeah. Thank you. So we have to do cholecystostomy tube for the relieving of the symptoms. Okay. So this way you have to remember. So see Dr. Sneha's case, patient burnout and cholecystitis. My presentation is cholecystitis, but it is not that. It is not that patient actually cholecystitis case. No. So see the causology condition that might have elevated liver function, but not directly. Some condition which raises SGLT-LP. What are the condition like severe septicemia? Hepatic ischemia like Dr. Hirar case, hepatic ischemia. It is not related to the patient's cholecystitis spectrum. Patient pneumonia, severe ischemia. That's the SGLT 1000. It is not due to the cholecystitis presentation like Dr. Sneha's case, severely burnout. Now cholecystitis. ERCP, cholecystomy, no. Some medication, liver hematoma, acute pancreatitis, appendicitis, pyelophyrobitis. So these are the causology for having increased liver function. So we have to manage according to the symptomatic management. Okay. So liver function, LTST, why I am this picture highly important for the exam, mainly these two pictures. AST/ALT will be more than 2 times higher in alcoholic patient, less than 1 time lower in hepatocellular necrosis. So we have to remember very strongly. It will be elevated in NSAIDs user, AC inhibitor users, alcoholic users, alkaline phosphatase, obstructive fluke, cholestasis, stasis, GGT elevated in the alcoholic patient, warfarin taking patient, bilirubin always obstructive picture, unconjugated hemolysis if remain, conjugated if there is any bilirubin or bile duct stasis, okay, and prothrombin higher if there is any hepatocellular disease. So these liver function tests all must to remember. First question will be discussed with me, Dr. So Dr. Maha Umer.
Yes, ma'am. An elderly patient admitted to the ICU with acute myocardial infarction and developed pneumonia on tazocin. He also have a right upper quadrant pain and tenderness. What is your management? ERCP, emergency cholecystectomy 3, convert from tazocin to meropenem. for ultrasound guided cholecystosomy drainage.
I discussed right now. Just remember what I said, Dr.
When
Maha. Okay?
patient, yes, when
Mm-hmm.
patient is in ICU and with MI history,
Mm-hmm.
so ERCP is not the option if we proceed with excluding method. Emergency cholecystectomy, not madam, and convert from Delsin to meropenem. Option 4, ultrasound guided cholecystosomy drainage, because patient has history of MI. So patient had a right upper quadrant pain tenderness. So we will go for with option 4.
Excellent. Thank you, Dr. Maha. Thank you. Excellent done. This is the way we have to do understand that, yeah, my candidates are hearing my session strongly. Thank you. Answer is 4. Second question will be discussed with me. Thank you, Dr. Maha.
Ma'am, thank you, ma'am.
Dr. Anjana is here.
Yes, ma'am. Good evening, ma'am.
Good evening.
A 37-year-old woman presents to the ER with a history of right upper quadrant pain, side 48 hours with nausea and vomiting. On examination, there was marked abdominal tenderness. Abdominal ultrasound showed pericholecystic fluids, thick gallbladder, positive sonographic Murphy sign. What is the recommended treatment? A. Conservative treatment with interval cholecystectomy. 2. Insertion of percutaneous cholecystectomy. 3. Emergency laparoscopic cholecystectomy. And 4. Emergency open cholecystectomy. So this is a patient of acute cholecystitis, and patient looks stable. So I think it is 1, conservative treatment with interval cholecystectomy.
But patient, you are a doctor of the emergency and patient present in emergency with history of the right upper quadrant pain 48 hours and
Hmm.
also nausea vomiting. You done examination and you are on examination there is the abdominal tenderness. Abdominal ultrasound reveals there is the fluid in perichocystitis. Okay. So you are doing examination and you are doing the investigation and there is thick gallbladder with positive sonographic Murphy sign. So doctors think you are a doctor of emergency department. Patient come to your hospital with right upper quadrant pain for 48 hours. You are doing examination, investigation. Investigation reveal there is a fluid and there is a thick gallbladder. And what is the recommended treatment? Is it emergency or not?
Yes, it is. So insertion of percutaneous cholecystotomy tube.
Insertion of percutaneous cholecystomy if the level of AST/ALT is not related to the my liver or gallbladder option. It is due to any portal hypertension, burnout, any other cause. But your case typical a case for the gallbladder pericholecystic fluid and typical case for the gallbladder sludge and abdominal pain due to the gallbladder stenosis. So this is not a false positive, it's a real case for the gallbladder or cholangitis sludge case. So acute cholangitis like picture demonstrated here, what you have to do right now?
Uh, Emergency laparoscopic cholecystectomy.
Yes, it's the emergency. So doctor, try to understand the question. Okay. First of all, think yourself. I am a doctor and these are the patient. It is not a ICU patient. It is not a MI patient. It is not a septicemia patient. No. Patient, typical patient. Patient, liver condition patient. Gallbladder, there's this called status fluid there. This is the liver condition patient. So I have to treat this case. So how I will treat this case? It is emergency. 48 hours patient suffering. So I have to do emergency laparoscopic cholecystectomy. Doctor, clear?
Yes, ma'am.
Thank you. So there's a 4 question what I will discuss one by one. 3 questions there. First of all, doctor, it's a just for one information, that is Shamim Shahid. I actually, unfortunately, I can't remember your name. What was your name actually? Shamim Shahid.
I'm Dr. Mavish.
Oh, Dr. Mahesh. Okay, okay. How are you, doctor?
Yes, ma'am, I'm fine. Thank
Okay.
you.
Okay. So, doctor, it's a Dr. Rehana is here.
Yes, ma'am.
Yeah. First question.
What type of gallbladder stones is seen in sickle cell anemia? Mixed, pure cholesterol, black, brown.
It's a basic
Uh,
question. Okay, that is sickle cell anemia patient present to your hospital gallbladder. It's a common question. DHA common question. Okay.
yes,
So even I always strongly emphasize on ALA edited note what I given. So in this question, two question you will face. One question is from them. So this is the question. Just try to understand what stone we will find out in sickle cell anemia patient.
because of hemolysis, I think black colored stones.
Okay. Just I'm waiting for other response. Dr. Saba Jisan. What is the answer? Okay. Dr. Sashma, what is the answer?
Ma'am, now the answer is C, black stone, because of the hemolysis occurring sickle cell anemia.
Okay. So where we will find out mixed variety? Where?
Uh, I exactly don't remember, but I have studied this this particular
Okay.
question, but I
Okay, no issue, no issue. I'll discuss. So I want to know regarding the mixed variety and black. So where I'll find out mixed variety? Any candidate want do know that mixed variety? Which condition I'll find out?
sickle cell
Ma'am,
trait.
sickle cell anemia.
Sickle cell anemia. So what? This is the case of sickle cell anemia. So what is the answer?
Mixed.
Mixed, ma'am.
Mixed. Clear? It's a mixed. Okay. Black variety hemolysis, but they didn't give any hemolytic picture for the black variety. Sickle cell anemia, mixed variety. Black variety, yes, sickle cell anemia, they given hemolysis ongoing, it will be the black. This question two-way direct question, it will be the mixed variety. If they give any picture of the hemolysis, it will be the black variety. Doctor, I'm discussing with Dr. Uh, Dr. Rehana maybe, right? Clear?
Yes, ma'am. Yes, ma'am.
Clear?
Yes, ma'am.
Okay. The second question, this one, this question. This question will be discussed with me. Does Shruti able to talk with me?
Yes, ma'am.
Okay. This
An old
question,
age,
yeah.
an old age patient came to the ER complaining of right upper quadrant abdominal pain with fever and jaundice. BP is 80 by 50, pulse rate is 125. Ultrasound showed dilated common bile duct, 13 with pneumobilia. What is the next management? Polycystectomy.
Shruti, you have to read the question again and try to understand what they ask. What they ask, try to understand. But I always suggest try to understand the question. What they ask and what they given. And you have to read again and tell me, ma'am, these are the clue. And I am so see, Dr. Shruti, one strong point here you have to do next. What is the strong point?
And BP is 80. Patient is coming to the ER complaining of right upper quadrant pain, and his BP is 80 by 60, which is low, and pulse rate is high, tachycardia. And so maybe ma'am, it is IV fluid and resuscitation.
Yeah. So see, you know the scenario. But the thing is that if we don't think, or if we don't work our brain, it will be the wrong. So answer is the IV
IV
fluid
fluid
and
and
anesthesia.
resuscitation.
Clear, Dr. Shruti?
Okay, ma'am.
Yeah. So see, all countries, I always believe that is the way and that is the aim of the course, to try to understand the question. Okay, and this is the clue, and everything, every kind of martial art know. But the thing is that we have to know why, what is the next, and what is the management. Third question will be discussed with me, Dr. Shamragya Priya.
Yes, ma'am. Good evening, ma'am. A 70-year-old man presents with abdominal pain. Examination revealed a pulsatile abdominal mass that is felt on deep palpation with mild tenderness just above the umbilicus. Blood pressure is 110/70 millimeters of mercury. Heart rate is 76 per minute. Respiratory rate is 14 per minute. O2 sat is 99%. RBC is normal. Hemoglobin is normal. Hematocrit is normal. Platelet count is normal. WBC is high. Sodium is normal, potassium is normal, bicarbonate is normal. Upper chest X-ray, there is no air under the diaphragm. Which of the following is the most appropriate lab investigation to be ordered next? Option 1 is chloride level, 2 is amylase level, 3 is calcium level, 4 is ABG.
Dr. Priya, I want
Yes,
to ask
ma'am.
a question that there is a pulsatile abdominal mass. What is the diagnosis?
It's abdominal aortic aneurysm, ma'am.
Okay, excellent.
Yes, ma'am.
Same question frequently asked in the exam. Abdominal aortic aneurysm patient come to your hospital and there is a pain. This is the correlated with which picture? Abdominal pain, mild tenderness just above the umbilicus. Same picture, what you think other than aneurysm is there, but there is a complication. Anyone? We have to think one.
Pancreatitis.
Pancreatitis, ma'am.
Amylase.
Pancreatitis. Yeah, it's Dr. Priya, clear? Pancreatitis,
Yeah,
okay?
okay. Yes,
So
ma'am.
what
Then
you will do?
amylase
Um,
level, ma'am.
yeah. Clear, Dr. Priya? We
Yes,
have
ma'am.
to
Yes, ma'am. I
think
got it, ma'am.
same picture, frequently exam question, we have to think it's a pancreatitis and we have to do amylase level. Hmm? Okay.
Yes, ma'am. Yes. Thank you, ma'am.
So yeah, this is the ERCP value. You have to just see, do the biliary stones is there, and the sphincterotomy of the papilla. Okay. So see, teach you already inserted here. You see, okay, and PTC we are doing for the dilatation. Just remember. First question will be discussed with me, Doctor. It's a Doctor Priscilla is here. If Dr. Priscilla not here, Dr.
Yes, ma'am.
Nipuni.
Sorry.
Okay, Dr. Priscilla.
Sorry. Question one. Patient came back from holiday with right upper quadrant abdominal pain and tenesmus. On examination, enlarged liver, classic case of liver abscess. Symptoms and sign. Best investigation. A. Ultrasound abdomen. B. Serology. C. CBC. D. Blood CNS. A. Ultrasound abdomen.
Dr. Priscilla, a patient
Yes, ma'am.
abdominal pain, thymus mass, enlarged liver, and you are
Mm-hmm.
thinking that's abscess. So initially, before ultrasound, we can do some lab.
Okay.
Is there any
Then I'll do
whatever the organism? So you
organism.
can do you can do PCR serology based investigation for pyogenic liver abscess, amoebic liver abscess. You have to do the serology test. Though
Hmm.
best investigation we can do ultrasound, but the thing is that right after this is the indirect question. Basically, it's an indirect question. Why? If they ask me initial investigation, okay, we can do serology, but they said best, and you are asking ultrasound. from if I am on your side, I can also mark ultrasound. But the thing is that enlarged liver, they emphasize the one point, the serology. Is that an amoebic liver abscess or other causology of the abscess? So they mark serology according to their thinking. It's the best, not initially. Okay, and they said, you said this enlarged liver, classic case of liver abscess, symptoms and signs already they posted like that, fever, tenderness. Okay, so
Yes.
no need to ultrasound right now. So we have to do, so liver abscess, we have to do serology first. If
Yes.
liver abscess, serology first, right?
Yes,
Okay.
ma'am. Okay. Understand. Okay. Thank you.
Second question will be discussed with me, Dr. Badhan.
Yes, ma'am. Patient with right upper quadrant pain, tender hepatomegaly, CT revealed double target sign, aspiration, and Kuvisow's appearance. What is the most appropriate treatment? Surgical resection, metronidazole, percutaneous drainage, and cephalosporin. Okay, Anchovy-sauce causes goes for amoebic liver disease. Uh, yes. So the most appropriate treatment is metronidazole.
Okay, excellent. First of all, aspiration and Kuvisow's appearance, double target sign. So it's the amoebic abscess. Doctor nicely said by Dr. Badhan. So it's amoebic liver abscess. We have to must correct by metronidazole first, right? Excellent.
Yes.
Thank you.
Thank you.
This question will be discussed with me, doctor. Mr. Fatima is here. If Dr. Fatima not here, so Dr. Shamim will be discussing this case with me. Shamim Shahid.
Yes, ma'am. 15-year-old boy present with a 5 days history of right lower quadrant pain and fever. On examination, he has right lower quadrant and right upper quadrant tenderness. CT abdomen with the contrast demonstrate multiple densities in the right lobe of liver, a phlegmon in the right lower quadrant and stranding around SMV with the bubble within the SMV. Total bilirubin is 30 millimole per liter elevated, alkaline phosphatase 2.6 elevated. What is the most likely diagnosis? Portal pymia, amoebic liver abscess, malignant carcinoid, and inflammatory bowel disease. Multiple densities in the right lobe of liver. Amoebic liver abscess.
Multiple density here, right?
Yes, ma'am.
Here, multiple density is the option and clue. The multiple density, if for amoebic liver abscess, we will find out hypoequic shadow or hypoequic field any shadow or honeycomb appearance in the CT scan. But your case is that what? That your case that there is a CT abdomen find multiple density. So no honeycomb appearance for the abscess here, right?
Okay,
So
ma'am.
this multiple density you see, though your picture goes towards the abscess, but one point you have to remember that 5-day history of upper quadrant pain fever, and he has right lower quadrant pain and upper quadrant tenderness. Multiple density is not amoebic like or anything that they said. Right lobe of liver, there's a phlegm on the right. So phlegm appearance. It's a phlegm appearance. Okay. And
Okay, ma'am.
bilirubin high, alkaline phosphatase high. It's an obstructive picture, right? Alkaline phosphatase high.
Yes, ma'am.
So if I say inflammatory, my excluding method, inflammatory bowel disease excluded.
Yes,
Malignant
ma'am.
carcinoid excluded. Amoebic liver excluded as This is not any clue towards the amoebic. There's no hypocrisy, there's no honeycomb appearance. Okay, CT scan finding. So what is that? It's a
Portal finding.
portal. This question is so easy to understand, but somehow they ask this question. The thing is that there only one differential point. Question is not easy. Multiple densities towards the right lobe of liver, and there is a flangum appearance in the right lower quadrant. Okay, and
Okay.
there's a
Okay, ma'am.
bubbles. There's a bubbles in SMV picture. So all
Okay.
goes towards the pyomeia. Okay.
Okay, ma'am.
Yeah.
Thank
So
you.
I am this. Thank you. Pyogenic abscess. So see, pyogenic abscess is a hot abscess, male predominance. Male are the suffer more. Right lobe common. Dr. Shamim's case. Mehis, actually, I know her by Mehis name, so it's nice to meet. So by name the Mehis. And Mehis case was Mehis the right lobe liver phlegm along with the SME pictures bubble. So singular multiple abscess. So see, multiple abscess, right lobe common, and infective organism invade liver directly and spread toward the lung, skin, and other organs and biliary tract. So biliary tract cholangitis abscess underlying like septic cholangitis, it could be the biliary stenting, it could be the sclerosing cholangitis, it could be cholangiocarcinoma. So these are the biliary tract cholangitis abscess. Portal vein, it could be the pyemic, like Dr. Mehi's case. Pyemic, portal pyemia. Portal pyemia followed pelvic GI infection leads to portal pylophlebitis. It could be due to the pancreatitis, perforated ulcer, diverticulitis, appendicitis. So it's also a pathology for the pyogenic abscess, but it is a portal pyemia. Right lobe common, bowel appearance, multiple nature. It's not one, it's a multiple nature. It is not septic cholangitis, it's not sclerosis. It's just multiple, it's due to the pyemia, pyemic abscess. So pyogenic abscess, most common cause bacteriology, aerobic, E. coli, Klebsiella, sign symptoms, it could be the endocarditis, anaerobic, Bacterius fragilis, most common. We have to do right treatment, WBC will be high, ESR will be high, blood culture, you will find out the organism. So pyogenic abscess, ESR, WBC high due to infective package, Dr. Mahesh case, alkaline phosphatase over high, bilirubin over high, so it's an obstructive picture. And extra finding elevation of right hemidiaphragm. This way they ask in the exam, DHA candidates. Elevation right hemidiaphragm, right basilar infiltration. Ultrasound, so see, hypoacute shadow, hemidiaphragm elevated, okay, extended, but the CT scan finding honeycomb appearance. His case first, there's a hyperemia, there's a multiple bubble, there is a there is a multiple bubble signs, no honeycomb appearance. So the honeycomb appearance, cluster sign, multiple small abscess, the phlegm appearance, all goes towards pyemia. So pyogenic abscess, phlegm appearance, multiple abscess, we have to understand what they are giving the clue. So this way, if we understand ultrasound finding, honeycomb appearance, okay, single abscess, if this is single, only suggest coalescence signs. Neither multiple sign or multiple small abscess goes towards pyemia. Treatment, underlying cause, empirical antibiotic, specific antibiotic, 6 to 16 years, septicemia management if patient unstable or persistent septicemia, percutaneous drainage, CT guided or ultrasound guided or surgical drainage. Very important, very important for the exam, every step. Indication of surgical drainage, if there is an ascites present, multiple large abscess which cannot be drained by percutaneously, so you have to do surgical drainage. Outcome, just remember, outcome fatal if not treated. Neither If it is resolved with antibiotic, it's good. Neither it may towards the liver cancer. So till now I discussed the pyogenic. It could be the amoebic liver abscess presentation like the pyogenic, same. But the thing is that commonly they give a clue. My DHA candidates, traveling history. Okay, traveling history for the antibiotic histolytica, fecal route transmission, and presentation same as fever, infection or the colon site colitis like presentation. Okay, and symptomatic presentation, and there will be the leukocytosis, there will be the liver function test impaired, and positive antibiotic histolytica. So there's a right lobe of liver potentially they affected. So this way we have to remember. There is anchovy sauce apparent Dr. Badhon's case, pyogenic amoebic abscess. The meteorology is the answer. Anchovy sauce apparent. So see, this is the appearance. We have to do the aspiration due to the anchovy sauce appearance. We have to do the chest X-ray to see the flesh diaphragm. There's a round lesion on the ultrasound. Okay, so serology, ELISA will be do, enzyme immunosuppression you can do, but the treatment metronidazole. Dr. Badhan case metronidazole. If response, okay, we can continue it, and if no response, medical treatment we have to do percutaneous drainage. Surgical drainage, as if it is large abscess, if there is any secondary infection, if there is any rupture, we can do surgical drainage. Now, first question will be discussed with me, Dr. Nipuni is here. Dr. Somia.
Yes, ma'am.
Easy question. First question.
CT, can you hear me?
Yeah. CT.
Okay. CT finding of hepatic mass, encashment of the borders with progressive filling. A. Hepatoma. B. Hemangioma. C. MADS. D. Hydatid cyst. Most common progressive filling is the so it's B. Hemangioma.
Excellent. It's the hemangioma. Thank you. Excellent. Second question will be discussed with me, Doctor. It's the Nandini Sharma. Second question. Question 5.
Good evening, ma'am.
Good evening.
A 48 years old man presents for further evaluation of a new 17 centimeter right liver mass diagnosed on computed tomographic imaging that was performed for a dull right upper quadrant pain. The mass exhibit peripheral nodular enhancement on the arterial face followed by progressive centripetal fill in on the portal venous phase. What does the lesion most likely represents? Hepatic adenoma, focal nodular hyperplasia, hematoma, benign liver cyst, hepatic hemangioma. Ma'am, I guess it's a hematoma.
Yeah, it is A, B, C, D, E. What is the answer?
C, hematoma.
Hematoma. So first, Dr. C. The patient evaluation 17 centimeter right liver mass, and you done computed tomography reveal dull right upper quadrant pain and mass exhibit nodular enhancement. You see nodular enhancement, arterial phase followed by progressive centripetal fill in the portal venous phase. Centripetal fill in on portal venous phase. This is the clue. What is the answer? Anyone? Centripetal vein followed by
Ma'am,
portal
it's
venous
Hemangioma.
hemangioma. It's a hepatic hemangioma. It's a clue. Not
Yes.
easy because many countries may not be know, but the thing is that this portal venous phase goes towards hemangioma. Okay, it is not hematoma. Hematoma is like tumor like pressure. It is not towards the portal venous phase. Okay, doctor.
Okay, ma'am.
This question will be discussed with me, doctor. If Monia German is able to talk with me, if she can. Neither, doctor. Again, my circulation from it will it be started from Dr. Sneharaj. Okay. Dr. Sneharaj may not be able to talk. Dr. Anjana, tell me, Dr. Question 6.
Yes, ma'am. 34-year-old female on OCP presented with right upper quadrant pain after trauma. She is unstable. Unstable hemodynamics and signs of peritonitis. There is drop of hemoglobin and an operating room. You found a ruptured mass. That is most likely A. liver adenoma, B. hemangioma, C. FNH, and D. HCC. It looked more like a liver hemangioma.
Okay. First of all, Dr. Sneha, patient OCP taker. Okay. An OCP taker patient, right upper quadrant pain after trauma. Okay, she's unstable means already ongoing. Unstable means already ongoing bleeding. That's why. Hemodynamic signs of peritonitis there and drop hemoglobin due to the bleeding. So liver hemangioma, if you there's a rupture mass. This mass commonly after OCP taker it is due to the adenoma. This is the point. OCP taker rupture mass due to the adenoma. Hemangioma risk factor is excluded by only OCP taker. Okay, so answer is what?
Liver adenoma.
Liver adenoma. I'll discuss this question with you later. Okay, thank you.
Thank you.
Before these two questions, I want to discuss this adenoma and hemangioma picture. Then I will discuss those questions. So first of all, adenoma, Dr. Sneha's case. So see, right upper quadrant pain, hypotension like Dr. Sneha's case, pre-menopausal women like older than 30, the age was 35. So risk factor OCP, Dr. Sneha. Okay, OCP risk factor. So OCP risk factor for having adenoma. Though you are thinking hemangioma, bleeding, mass rupture, no. When they said OCP, so it's adenoma. Glycogen deposited risk factor rupture, okay, and transformation 5% CT hypervascular homogeneous tumor suffered colloid scan and tract RB scan. It will be the normal, but the thing is that surgery will do if it is more than surgery. When will do? If less than 4 centimeters, stop OCP, then serial CT to see. And if it is more than 4 centimeter, embolization if multiple pictures. So see adenoma picture. This is the adenoma, multiple pictures. So sometimes we have to do this serial CT to see the adenoma resolve or not to stop the OCP. More than 4 centimeter, we can do embolization or surgical excision. Hemangioma picture, I am discussing two questions, two candidates. Just see, this hemangioma picture is the most common benign. It is dissociative. Okay, so it's a large hemangioma. What are the symptoms? Large hemangioma can cause symptoms. So when hemangioma will be the large, patient will present to your hospital with pain. So in CT, hypervascularity, peripheral nodular enhancement, centripetal. Centripetal is a clue. Sulfur colored scan, no cell. Okay, and there will be the type RBC scan will be the positive. So centripetal is the important for the having hemangioma. When it will be the higher, it will cause pressure and it will cause pain. So treatment, you can leave it alone because it's a benign. If it is excessive symptomatic, we can do surgical excision. So two question, two way OCP related centripetal line related, we have to do excluded those way. So question 7 is two questions. 7 will be discussed with me, Dr. Sajma.
Yes, ma'am. A 36-year-old female patient present with right hypochondrial pain, CT done, hypervascular lesion with central satellite heart in technetium. What is the treatment?
So what is the
Uh,
diagnosis? First of all, what is the diagnosis? Clinical, I just discussed. Central
so
sterate line.
there is hypervascular lesion with central satellite line. It is hemangioma.
It's the hemangioma. Excellent. Then it is not
The
excessive. What we will do right now? Treatment is
uh, treatment is option A, stop oral contraceptive and repeat CT, observation, resection, cryoablation. It is observation.
observation. Excellent. Because we already discussed if symptomatic and patient is unbearable to is considered, we can do surgical inclusion if patient symptomatic. But it is not just patient present to my hospital with right hypochondrial pain with hypervascularity lesion on the CT, so we can do observe. Question 8 will be discussed with me, Dr. Hira.
Yes, ma'am. 30 years old female patient on OCP, 4.5 centimeter hypervascular cold and sulfur colloid, no peripheral to central enhancement, AFP normal. Treatments to stop oral contraceptives and repeat CT, resection, observation, cryoablation. Madam, it's uh, hepatic adenoma, and
Mhm.
we'll. Uh,
It is more than 4 fine with more than 4, so
four, ma'am, resection.
resection. Yeah. Clear, Dr. Hira?
Yes, ma'am.
It's a more than 4, so resection. Thank you. So malignant hepatocellular carcinoma and focal nodular hyperplasia. Just shortly, I want to discuss. First of all, focal nodular hyperplasia, most commonly in women in 30 to 40 years of age. It is not hereditary. It's a focal nodular hyperplasia. Malignant transformation can be caught, but it is rare. In CT scan, central stellate line as like hemangioma, but I have to remember there will be the Kupffer cell and RBC scan will be normal, but in hemangioma, RBC scan will be the positive and AFP will be normal. This is the variation. It's a hyperplasia. See, there's a hyperplasia. Okay. So malignancy, HCC, common exam question. Risk factor, any hepatitis B, C, alcoholic patient, cirrhosis, presentation, jaundice, ascites, weight loss, CT tryphasia, hypervascular in arterial phase, hypodensity, okay, MRI variability, hyperintensity. The most common cause of HCC is the metastasis from the colon. So we have to, the metastasis from liver cirrhosis or liver cancer from the colon. So we have to understand this HCC, any kind of hepatitis B or C virus, it causes cirrhosis and it causes cancer. So question 9 and 10. Question 9 will be discussed with me, Dr. Saba.
Question
Exam
9.
question.
Peak
Yeah,
of
very important.
hydrated cyst on ultrasound, it was big, but the size was not mentioned. But daughter cyst was mentioned. What should you do? A. Albendazole. B. Surgical deferring. C. Percutaneous drainage. And D. Liver resection. Ma'am,
Hydrated
it is.
cyst, it's a big size not mentioned. Commonly what we do?
So, ma'am, we.
Hydrated cyst, exam question. In Ala note 2 to 3 point they given nicely. Even it I in my exam they saw this was the question two way they asked. Okay.
Ma'am, C. Percutaneous drainage.
No, first of all it was big. If I say 1 point multiple daughter cell, what will be the answer? 1 point I already say. Daughter cyst here, multiple daughter cyst. The same way they ask in the exam. Multiple daughter cyst if there. So how you will do the drainage? Because multiple daughter cyst. Daughter means conjugated. What
Ma'am,
is the
then
daughter
we
like
will be.
this? So how will be the how will do the pertinent? This is the daughter cell. So what is the
Ma'am,
answer?
liver. Then we will done with the liver resection.
Multiple daughter cyst. multiple daughter cyst? One answer, clear cut.
Ma'am, surgical deferring.
It's a surgical deroofing. My dear, every candidate just for today, remember daughter cyst means I have to do deroofing. Okay?
Okay, ma'am.
Okay. Second question will be discussed with me, doctor. Dr. Maha Umer.
Yes, ma'am. Elderly asymptomatic with liver mass 8 by 8 centimeter confirmed to be hepatocellular carcinoma. What is the best management? A. Chemoembolization. B. Radiotherapy. C. Reassurance. D. Surgical axial. Ma'am, B, C option is not A and D option. Patient is asymptomatic and elderly.
So?
8 by 8 centimeter. Best management on chemo embolization.
Excellent. Dr. Maha's performance good. First of all, Dr. Maha excluded nicely. BC excluded radiotherapy reactions, but the thing is that it's 8 so it's no need excision now. We can do chemoembolization because patient asymptomatic. If patient symptomatic, we can do excision, but patient asymptomatic, we have to do chemoembolization, right?
Yes, ma'am.
Thank you. So thank you. Hydrolysis shortly I want to discuss regarding this hydrolysis question. Actually, they discussed from the management method individual with the answer D roofing surgery for the multiple orthosis. Radiological finding watery ill cyst and daughter cyst most characteristic sign. Daughter cyst most characteristic sign I surgery note I given. Samur surgery note from the hydrolysis question. All they give nicely noted. Strongly remember those Simon surgery note, okay? Then last finding you see eosinophilia and there will be the complement fixation and hemagglutination test there. So LIC will be there. So see, hydrolysis question we have to remember this way and it's a surgical repair. Surgical repair, there is a mercifulization we can do. Indication of surgical repair if lesion more than 5 centimeter, multiple cyst, if accessible to puncture, infected cyst, we can do surgical repair. Okay, and contraindication if there is an inaccessible, inactive condition, cyst communicating with the biliary, so you can't do surgical repair, surgery or mercifulization. So you have to do only surgical repair surgery. Surgical per indication, contraindication, just remember. Last two questions, one question will be discussed. This is the last question for today's discussion. Question 11 will be discussed with me, Dr. Somia. 11.
Yes, ma'am. A question about liver lesion. Patient complaining of right abdominal pain for 3 months. Report shows hypervascular lesion. Lab shows increased alpha fetoprotein. Okay, A. Hepatocellular carcinoma. B. Mats from the GI. C. Cholangiocarcinoma. D. Choledochal cyst. Hypervascular lesion, patient complaining for 3 months. Hypervascular lesion, lab shows increased alpha fetoprotein. So answer is A.
Yeah, answer is excellent.
Because alpha
First of all,
fetoprotein raised
got
in
it?
hepatocellular.
Yeah, excellent. It's the answer. Another clue is that PT apetite high. PT apetite high means it is HCC. Okay.
Oh,
So liver lesion PT complaining of right abdominal pain, but PT high or PT lesion, prothrombin appetite high, all goes towards the FFP is high, also goes towards the malignancy. Okay. Same way, another question, another recall, doctor. Remember that the hepatitis C, old patient, weight loss, fatty, ultrasound as a mass. So diagnosis what, doctor?
carcinoma.
Carcinoma. Yeah, thank you. Last question will be discussed with me, doctor. Anjana.
Yes, ma'am. 73-year-old woman presents with new onset jaundice. There is generalized fatigability, weight loss, and loss of appetite. CT scan shows replacing multiple lesions replacing approximately 70% of the liver parenchyma. Which of the following is the most appropriate management? Colonoscopy, upper GI endoscopy, percutaneous biopsy, and diagnostic laparoscopy.
think
So
colonoscopy.
basically, it is showing some new onset it, carcinoma kind of a picture because there is weight loss, there is fatigability, and there is a new onset jaundice also, and there are multiple lesions. So I think C, percutaneous biopsy.
No.
First of all, doctor, see, patient is 73, right? And patient presented with jaundice. So if we think age is 73. Patient complaining of weight loss. So which is the red flag sign? Weight loss, loss of appetite, right? Multiple lesion. Okay, so all are the red flag sign. Kindly mute the mic. Okay, so all are the red flag signs. So we have to think what Dr. Anjana remember. All are the red flag signs. So what is the answer?
Mm, diagnostic laparoscopy.
So if you do the diagnostic laparoscopy, what you will see? CT scan showing multiple lesion. So I said 1 point, always multiple lesion, always this age is a value for having metastasis from the colon.
Colon.
So what is
Okay.
the answer?
Colonoscopy.
So you have to do colonoscopy. Very important. Same exam question. Same. We have to do colonoscopy first. Age and metastasize and multiple lesions. So you have to do the colonoscopy. Clear?
Clear. Okay, ma'am.
So tumor mark of the liver, that benign lesions. So see, if we do the ultrasound, it could be the solid. If it is solid, we have to think in the malignancy. Benign, it could be the cyst. If there is any abscess, simple. Okay. So after doing the ultrasonography, we have to do the triphasic CT scan, hypervascularity according to the hypervascularity of the malignancy, and non-enhancing. We have to do the CT thing. So today I cover maximum question from the hepatobiliary system, which is the common question in the exam. So remember this way. Thank you, my dear conduits. So I'm ending my session. I hope all enjoyed my session. Thank you. Assalamu alaikum to all. Okay.
Thank you, ma'am.
Thank you,
Thank
ma'am.
yeah. Assalamu alaikum.
Allah Hafiz, ma'am.